Thank you everyone for joining us for another Learning Lunch hosted by Format Approved. My name is Brian Johnson. I'm the Senior Director of Online Education with Format Approved, and I'll be your moderator today. Today's Learning Lunch will cover meaningful use, a state of confusion. Today's session is presented by Jim Tate of EMR Advocate and MeaningfulUseAudits.com. Jim is one of the top meaningful use experts in the country, and he's helped guide both eligible professionals and hospitals through the audit and meaningful use processes. He offers invaluable real-world insights into meaningful use, and he has a wealth of advice on how to avoid audits and what to do if you should be audited. You can read more about Jim's expertise there on your screen, and to be sure, we're going to send the slides out so you can review all of these materials at your leisure. Let's take a quick glance at the questions for today's session while I go over some housekeeping notes. Remember that you can ask questions of Jim at any time during today's session by entering them into the chat area. In the second half of our session, we'll save some time for questions. If we do run out of time, we'll pass your questions on to our presenter, and he can respond to you via email later after the session. But we'll get to as many questions as we can. Also, some of you have already asked about this. Remember that all registered attendees of today's session will receive an email with links to both the slides of the event. People always ask for the slides, but also a video recording. So if you'd like to share this with anyone else, you'll certainly have that opportunity. All right, so Jim, first of all, thank you so much for joining us. It's a real pleasure to have you here.
Brian, good to be back with you again, and I look forward to talking over some of these topics with you today. And let me just say off the top, I am a big advocate of the transition to an interoperable electronic health record system. There's no doubt about that. And I think we're on the path to that. But especially in the last few months, there has been a lot of confusion. And some of these topics, I think, that need to be a little more attention brought to bear, need to be talked about. So I'm kind of glad we're going to be discussing a few of those things today.
I certainly agree, and already we can see questions from our audience. There is a lot of confusion out there. Let's start with our first question. So ICD-10, I think most people know now that the deadline was pushed back. What happened with ICD-10?
Yeah, it's fascinating. Actually, ICD-10 is not part of the meaningful use because ICD-10 is a diagnostic coding system. What's really required for meaningful use for 2014 and on is SNOMED coding. But I thought this is indicative of some of the problems that we're having as far as policy healthcare policy being enacted and implemented. And so ICD-10 goes back to the 1990s. By the year 2000, most of the world had converted ICD-10. We are eventually going to go to ICD-10. There's every reason in the world to go to it. We need to go to it. A lot of the world has gone to ICD-11. But the issue that I had with this is that it had already been delayed. At least there had already been one major delay. And as recently as, I guess, February, CMS at the HIMSS conference this year said there would be no more delays. And hospitals had put out contracts, had hired coders, whole business systems had been created. Everybody was getting geared up for a major transition. And then out of the blue, a congressman from Pennsylvania decided he was going to stop it. And so one sentence was put into a bill in late April, in a bill that had to pass. And that one sentence said ICD-10 would not be enacted or required until at the very earliest October 1st, 2015. The deadline had been October 1st, 2014. That bill was passed by the House without a roll call vote. And if you go look on YouTube, you can see it happen in about 30 seconds. So the fact that healthcare policy, which was had been agreed upon and from top down by the people we hired to do our healthcare policy, make sure it happens, was stopped cold. And so it was really a last minute in the dark, without transparency, without notification. a 1 year minimum delay. If they could do that, then they could do it again. So that kind of undercuts the credibility of all of it. Who did it is Representative Joe Pitts from Pennsylvania. What it means is that there's a minimum 1 year delay. CMS says it will start October 1st, 2015, but as we found out, it could be stopped again. And the reason to me that this matters is that with all the planning that has been done among stakeholders and hospitals and providers and everybody getting ready for ICD-10, just literally in a 48-hour period, the blanket, the rug can be pulled out from underneath our feet. And so to me, it really struck at the credibility. Everybody who's been involved with this was really shocked at this. So that's why I think it matters. So we will go to ICD-10, but when you talk to people now about the deadline next year, their attitude is, well, we'll see. So a lot of money, a lot of planning was put into it for this year, and it was just kicked aside really in the dark of night. I think it was just very bad healthcare policy for elected representatives to do this. So I'll get off my soapbox about that one, Brian, but it's not good healthcare policy to have things happen like that.
Well, it's clear, I think, that CMS was determined to move ahead, and then it really wasn't in their hands. It was taken out of their hands by Congress.
Right, and if that can happen for ICD-10, they can do it with anything else. And again, no transparency whatsoever, and I kind of like transparency. And without transparency, it's hard for hospitals and other stakeholders to plan. We're going through a period of giant transition, so difficult to plan.
Well, that brings us to meaningful use, where there's kind of similar things afoot. What is the proposed rule for 2014 when it comes to meaningful use? Explain what's changed.
Well, see, I guess it was 4, 5, 6 weeks ago, Brian, I was taking a nice nap on my couch. And one of my colleagues called and woke me up and said, "Did you see what they just did?" Well, I didn't know what that meant, but it didn't take me too long to look at a Twitter feed to see the proposed rule that had come out. There has, one of the things that I really have liked about the whole meaningful use program is that as there's been the benefit and the ability to change as things went along. When we need a little more time, the system was tweaked, additional time was given. When it became obvious that some of the things in 2011, 2012, like electronic exchange of key clinical information, was difficult to audit and maybe didn't really make a lot of sense, they decided they wouldn't require it in 2013. So mid-course corrections seemed like a good thing, but then out of the blue, we got this proposed rule for 2014 meaningful use. I'm trying to think now, I don't know if it was May 20th or May 23rd, but it was introduced, maybe it was in the Federal Register on May 23rd. There's a 60-day public comment period. Very easy to do a public comment online about this. But what it essentially says, the things, I kind of call it, Brian, the zombie rule, because it brings back a dead certification. 2011 edition certified electronic health record technology, we've been told for years was going to die at midnight, December 31st, 2013. So it couldn't be used for meaningful use this year. So all providers, all vendors, everybody considered that after that date they needed 2014 software. And so the proposed rule says that, well, and there have been some problems with vendors getting 2014 certified, rolling that out to users so they could use it this year, even though they don't have to do it for 90 days or a quarter in some cases. So some problems there. And so the proposed rule is that you can achieve meaningful use in 2014, again, whether you're an individual provider, a clinic, or a hospital. You could use 2014 edition software or 2011 edition software that theoretically was gone forever last December. That could be utilized, or a combination of the two. Now, one reason this is somewhat confusing is that for a lot of vendors, they no longer have that 2011 certified version. They figured it was no longer viable as a way to attest to meaningful use, so they have, on their way to 2014 certified edition software, they've come up with new versions, maybe an interim step. And so the versions that are out being used by their providers now, maybe not 2014, but they are no longer that certified 2011 version. So that's kind of up in the air. So there's a possibility we may be able to test this year with 2011 or 2014 software. Also, big effect on the stages. There were a number of providers who had been at stage 1 for at least 2 years. They started in 2011, they've been at stage 1 for 3 years, 2011, 2012, and 2013 because of the extension. Supposed to be at stage 2 this year for at least 90 days or a quarter. The proposed rule says if they're not ready to do stage 2, they don't have to do stage 2. Instead of doing stage 2, they could do stage 1, meaning they could theoretically, eligible professionals, do, under the proposed rule, 4 years of stage 1 with 2011 software. This was all well and good if this was a final rule and people could plan on these things. But since this is a proposed rule, which means 60 days of public comment, which will take us down to, I believe, pretty close to July 23rd, near the end of next month, and then review of the public comments, and then the final rule coming out in August or September, that is very difficult to plan on. The reason why is if this rule was finalized right now, and you could use 2011 software and do stage 1, people could attest right now. But the only clear path going forward is really just to ignore the proposed rule, because by the time the rule comes out, it may be too late to change, and we don't know what that rule is really going to say. So that's thrown a lot of confusion into everything, Brian.
So you're saying that it's possible if they were to not actually keep the rule in its proposed form, if you went ahead and used, 2011 certification to certify for or to attest for stage 1, that might not satisfy what they're actually going to come out with. Is that what you're saying?
Well, that's exactly what I'm saying. And right now, since it's proposed rule, we don't know if that will be in the final rule. We don't know.
So a lot of uncertainty.
A lot of uncertainty. If this proposed rule had come out 6 months ago, there would have been time for it to be finalized, and so some planning could be done. There's a lot of uncertainty. Within a week or so, people were contacting me wanting to know if they could go ahead, use 2011 software and attest for meaningful use this year. Well, no, they can't. You have to wait till that final rule comes out. Depending on what that final rule says, you could find yourself in a corner. My advice for everybody is just to be aware of the proposed rule, but to ignore it and go ahead and do what you knew what was required for meaningful use incentives this year, whether you have to be at stage 2, that you have to have 2014 software. If you can't get 2014 software in time, there's already the ability to apply for hardship exemptions. So beginning in 2015, you don't have that 1% Medicare fee adjustment, as they call it. So there's already something in place if you're having difficulty getting that 2014 certified edition rolled out to you and achieving meaningful use with it.
Is that part of what's gone on here? I mean, I hate to go off script, but I'm just curious why they've done this. Is it because I've heard a lot that the process of certifying EHRs for 2014 has been much slower than they had hoped. Is that part of why they did this?
Well, I think that is part of it. It has been much slower, and we'll get into some of these things in just a few minutes, Brian, but stage 2 is also going to be, there's a lot of workflow and technical complications around stage 2.
Well,
And
why don't we move
so,
on to that question then? What are some
yeah,
of the
sure,
challenges you're talking about?
exactly. Um, there's some interesting things about stage 2. It's not just necessarily higher thresholds. Uh, Patient engagement is a big part of stage 2. Whether you're an individual provider or you're a large hospital system, if you're going to achieve meaningful use in 2014 the way the rules are right now, no matter whether you're at stage 1 or stage 2, you've got to have a patient portal. And you have to be pushing information about your patients to that portal. If you are at stage 2, not only do you have to have the portal, but you have to have patients, at least 5% of your unique patients coming to the portal. So stage 1, you have to make the information available at a portal. If you're at stage 2, you got to provide that information, but a certain percentage of your patients have to actually come to that portal. So that is a new workflow for that stage 2 concept, and any hospital who's at stage 2 this year, was planning on being at stage 2, and there are a lot of them, has had to come up with some type of workflows or workarounds or systems to get patients to actually come to the portal. So that is a real challenge. It's the first time that meaningful use, a portion of meaningful use has been placed is outside really the control of providers. It's in the hands of patients. And there is part of that makes sense, because a doctor's office or a hospital is probably the best place for patients to be educated about a portal and how to log into it, and the benefits of accessing it. And so those, what patients have to do, they have to, again, if you're at stage 2, 5% of those unique patients have to either be able to view, download, or transmit their information. Well, to view is one thing. Download and transmit, you're going to have to view it, to download and transmit. So as soon as you view it, your information, that's going to count towards meaningful use. But a lot of hospitals are trying to work out how they can train patients to come to the portal. They're not getting a lot of guidance so far. Something else, and by guidance I mean workflow. Is it okay to walk around a hospital with a laptop and show patients and have them actually log into a portal, log into their portal before they're discharged? Is that allowable, or is that not allowable? Will that count towards meaningful use? So they're having to do those things right now without a lot of guidance in that area. Secure messaging is another big challenge. It's part of stage 2, and secure messaging involves sending information from one authenticated address to another authenticated address. And so if a provider has always had an email address of Dr. Jones at gmail.com, that is not authenticated. Every provider in the country who's going to be sending secure messages is going to have a new email address to be able to receive these secure messages. Patients also are going to have authenticated email addresses, not the ones that we have now. So the fact that that is a core requirement for stage 2, and a lot of people still don't know about that yet, that to me is a big challenge there. Just the infrastructure. Final one I kind of mentioned here, Brian. Hospitals having to send transitions of care summaries if they're discharging a patient, they go into a rehab or a post-acute care facility. They have to send transitions of care, a certain percentage of transition of care summaries electronically. And that's based on hoping those other facilities can actually receive that electronically. So there's some infrastructure that is really not totally in place right now. I think stage 2 is going to be really hard. If the proposed rule was finalized and everybody could be at stage 1 this year, that'd be one thing, but you can't count on it. So hospitals or anybody else who's going to be at stage 2 just has to assume they're going to achieve meaningful use this year, you got to be stage 2. So.
And really, what makes it incredible to me is the time is now. We're looking at July 1st for this quarter, so there's not much time.
You know, and you're talking about the eligible professionals.
Yeah.
That's correct. And so since, and it's kind of interesting, the timeline for eligible professionals, since they only have to do, under the Medicare program, 90 days on the tie of the quarter, they can theoretically wait and do October, November, December. If it's their first year in the program, they have to make sure they don't get the Medicare penalties that begin January 1st. They have to achieve meaningful use in a test no later than October 1st, meaning July, August, September is their last period to do a quarter. They can, those first year eligible professionals, do October, November, December, but and get the incentives, but they're still in line for those January 1st penalties. The only option, if that's going to be their case, is they can file for that hardship exemption, which would give them a grace period of 1 year. They won't have the penalties in 2015. But to do that, they have to file that document no later than July 1st. So we're getting pretty close to that. No doubt about that.
Well, we've had you on many times, Jim, to talk about the audit process for meaningful use and how robust that is. What's going on now with MU audits and appeals?
You know, that is has really been fascinating. Some of the things that I've seen in the last 2 or 3 months, Brian, we used to see almost all the audits that we saw were complete audits. All documentation that had been used for meaningful use attestation was requested by the auditors. Starting to see also, though, limited audits. And those limited audits usually are just requiring the proof of certified electronic health record technology. They want a license or a contract or some type of agreement that shows you actually do have that certified system during that reportable period. I've also seen more and more variation between the Medicare and the Medicaid audits themselves. Since the Medicare audits and there's some dually eligible providers, hospitals get may be able to get Medicare and Medicaid audit, incentives. So those dually eligible hospitals and everybody else who's in the Medicare program, any audits for them, complete audits, come from Figliosi and Company, who's the Medicare contract awardee for the audits. And they've been doing this 2 years or more now. They have a pretty streamlined process. They know exactly what they're asking for, and it's very consistent, one audit to another, as far as the process. But on the Medicaid side, since those are done on a state-by-state basis, there's a wide variation. And I've recently been working with some providers who are being audited because they're Medicaid eligible professionals, and some of the states are requiring things that I don't want to say this in a negative way, but shows that the auditors don't have a complete understanding of really what is auditable. And sometimes we have to explain to the auditor. I'll give an example. You know, it's very possible that somebody could switch an EHR in the middle of the year, so they achieve meaningful use with 2 different EHRs. That's fine with the government. You report both EHRs, and you can aggregate the meaningful use numbers. The Medicare federal system, I understand this very well, but sometimes at some of the state levels, there's a lot of confusion about that. So it's not quite as consistent. So I've noticed that more and more. I'd much rather go through a Medicare audit than a Medicaid audit, because with Medicaid, you're not quite sure just the level of consistency that you're going to be dealing with from the auditor side. Lost appeals. This is something that's just come up for the first time. If an audit is failed, they have an opportunity to appeal that audit. Again, if it's a Medicaid audit, you appeal to the state appeal level. if it is a duly eligible audit or a pure Medicare audit, you can appeal. You get a final determination, you failed the audit. There's some information that says you're going to get a recoupment letter, and here's your rights to appeal. I had somebody that I've been working with, they contacted me after they failed an audit, and they had appealed by themselves, and they hadn't heard anything for 6 months about, and they had actually gone back after 2 months and filed the appeal again, still didn't hear anything back, and they contacted me, and we had a search made, and it turned out that their original appeal, which had been submitted electronically, that's how appeals are, and they had confirmation that it had been received, it had been lost. And what we were told is that during the budget crisis, during that sequestering of all those funds, you remember that, Brian?
Sure.
2%, and they shut down parks and things, that a number of appeals were actually lost, and they had no record of them, although providers had a record that of acknowledgement that they had been submitted. So there were some real delays in there because there was some black hole that appeals went into. I don't know how widespread that is, but I'm aware of 2 cases with clients I've been working with. Something else on the meaningful use audits and appeals that is we've got there is that security risk analysis. I think we've got this on a couple of slides, Brian, but this continues to be a area of confusion and heartbreak, especially for eligible professionals, small groups, even large groups who didn't and still don't understand that this is a process that they're responsible for, the EHR vendors are responsible for, in which the goal here is like the goal of HIPAA, to protect health information. Here we're making sure that we protect electronic health information. So it's a review of technical aspects, physical aspects, administrative aspects, identifying risk, and coming up with a timeline to mitigate those risks. And risk change over time. So there's still a lot of confusion about this. And so very frequently I see providers contact me after they failed an audit, and the one reason they failed it is because they didn't have a security risk analysis. I said, well, what did you have? They said, well, we really didn't have anything. We change our passwords sometimes, but we don't have any proof of it. Well, it's a lot more than changing passwords, so that still is a big, big issue.
Well, yeah, we certainly encounter the same thing, and we are involved with doing risk analysis at Format Approved, and yes, every time we do them, there's always things that need to be remediated in those reports, whether it's workstations have patches that they need, or maybe more serious policy issues. There's always things that need to be improved.
Well, there's always risk, and just as time, if a practice opens a new office, well, there's risk there. That's something that needs to be addressed. If there's a new Wi-Fi system that's being set up, there's so many things that are involved in this, and what is the risk to the health information? To me, the risk is the same reason that people go after eBay and Target, identity theft.
Absolutely.
So if they can get in your system, they get your demographics, they probably get your insurance information, get your social security number. That's worth money. And so I don't know if they care if you have diabetes or not, but they want your social security number.
Absolutely.
So, and one thing, it just shows large organizations that have been hacked. You kind of I feel for a small practice or even a large practice, how safe can they make it? But, every effort must be made. The Office of Civil Rights, this is a civil right, and the breach notifications go to the Office of Civil Rights because we have a civil right that our health information is kept private and secure. So it's a big area. Always
so there's been a lot of buzz out there, if we could shift just a little bit, about, there's been a lot of pushback about meaningful use, I think because of some of the changes you've been talking about. So tell us more about that pushback.
Sure. Brian, there have always been naysayers. And it's difficult to go from a paper-based system to a computer-based system. And in some ways, I'm sure we'll look back in 10 years at the EHRs and the software we're using now and think it was probably very, very primitive in a lot of ways. But we have to start somewhere. So we've always had these naysayers who said they'll never do it and there's no benefit to it. And you always kind of just have to dismiss those because there's always going to be those. But in the last 6 months, I have begun to hear, and you probably have too, that some of the very, very credible people who are stakeholders in this transition in this industry, whose are leaders and whose voices I listen to, have started questioning that we need a simplification of the entire system. So such leaders as John Halakma, who's CIO in Boston and practicing physician and at Harvard, in his blog post, he talks about how it's starting to get complicated and that rules are written and regulations by ONC and CMS, and that sometimes he cannot even get answers to some things. So I think there has been a loss of credibility somewhat in the program. The delay of ICD-10 played into that somehow. The proposed rule that came out, we talked about is extensively. I work with a lot of vendors. I've worked with over 250 EHR vendors, and I talk to them every day. And their attitude is, well, we hear these rules are out there, but we don't know how much we can really rely on these rules, just because they can change. Again, the proposed rule to me was a giant change, and there's some things in it that are questionable to the degree that people don't know really what they can depend on. I'll give you another example that kind of feeds to this pushback. We had 2011 edition certified software. We have 2014, and theoretically we're going to have 2017 edition software. And it was introduced earlier this year that as a stepping stone, it might be good to have a 2015 edition software. It would be voluntary, meaning providers wouldn't have to use it for meaningful use. Vendors would not have to do it, but it might be a good stepping stone, just as it was such a giant shift to go from 2011, 2014 technology to maybe make it easier from 2014 to 2017, kind of have a stepping stone in 2015 so they go ahead and do some more interoperability, not have to wait and do it all for 2017. But and so every vendor, or most vendors, we're going to do this 2015 certification because of just marketing. If you're at 2014 certified and somebody else says they're at 2015, the sales paradigm, that's going to be used against you. But the regulations say that what is going to be in 2015, there's no requirement that that new technology will be part of 2017. So it's not a true stepping stone. So there's the way things stand now, the only reason to do, even with this confusion around 2015 certification, only real reason is for branding and marketing reasons. And so people will do it. So that, to me, kind of points towards that loss of credibility in the program. Diminishing incentives is also a giant thing. Incentives were front-end loaded for the Medicare system, and they're gigantically front-end loaded for the Medicaid system. And there are a number of specialties that I've talked to, radiologists, the anesthesiologists, a number of specialties who did what it took, just because it made business sense, to achieve those early stage 1 meaningful use when it was a relatively low bar, get the heavy front-ended loaded incentives, and then not do meaningful use anymore, not go to 2014 software, not go to stage 2, no intention to it whatsoever. So as the incentives are going down, now they're still up for Medicaid, and you can start, if you're a Medicaid provider, as late as 2016, get the full incentives. But for Medicare, those incentives are already diminishing, and we're coming up against the penalties. So the complexity of stage 2, diminishing incentives, loss of credibility, I think that's kind of led to, you see polls all the time about how many providers are not going to do meaningful use anymore, and I don't know if I really trust those, but just the fact that in the last couple of months I've heard more and more credible stakeholders who are involved in this and are committed to pulling off this transition to electronic healthcare system start to question things that, to me, that pushback is true pushback. So those are kind of the main things around it.
So what are some other things that providers need to think about with meaningful use here?
Sure. Well, of course, the first one I have up there, I mentioned it twice, that's security risk assessment. You got to do it. There's just no doubt about it. If you misunderstand it, you'll fail an audit and have to give the money back. If you do it yourself and it's just a checklist, you'll fail the audit and have to give the money back. One thing that I have seen as far as what creates a risk profile if somebody loses an audit, I've seen people lose an audit, maybe give an example, like for a 2012 attestation based on security risk assessment, and then 3 months later they're audited for 2011. Well, if they don't have a security risk assessment in 2012 or 2013, it would just make sense to me that you're first in line to be audited for earlier years. So the sooner something like security risk assessment can be fixed, because if you go through 4 or more years of incentives, you get audited the last year, and by the way, CMS tells us to keep the records for 6 years, so that to me that means they can be audited for up to 6 years, and you get audited for year 5. You don't have a security risk assessment. I wouldn't be a bit surprised if they go back and audit every year. And if you didn't have a security risk assessment in year 5, you're probably not going to have it in other years. So I've been preaching that for years, but if you don't have it, get it as soon as you can. We spoke about this a little bit, Brian, this 2015 penalties for not achieving meaningful use. And these penalties are Medicare, 1% off your Medicare receivable. So if you don't achieve meaningful use, for hospitals, this begins October 1st, 2014 for eligible professionals, January 1st, 2015, 1% 2015, 2% in 2016, it goes up to a maximum of, I believe, 5%. But the Secretary of Health and Human Services has the authority to change those percentages. So we'll see what happens with that. For those who can't make it this year because of troubles, for whatever troubles they may have, but one of the new exemptions, of course, is 2014 EHR-related issues, not being able to get that in time. There's that hardship exemption that can be used. And also, there are a number of reasons you can get that hardship exemption, but for eligible professionals, July 1st is the deadline to apply for that. Otherwise, January 1st, if you haven't achieved, and on the road to meaningful use would be those penalties. And switching EHRs, it's kind of a big thing, Brian. We heard a lot about it last year, that 2014 is going to be the year where a lot of EHR switching was going on. It's a nightmare to switch EHRs, but sometimes if you're not being satisfied, you've got to do it. Hard to move that data from one system to another. But part of switching EHRs, if you do it during a reported, what your meaningful use reporting period, you have to claim both EHRs. And during attestation, there's the ability to claim more than one EHR. And then those numbers from the old system and the new numbers, those numbers and denominators can be aggregated, and CMS says that's okay. They understand that. It's going to make the numbers a little bit hazy because there could be some problems when you're aggregating those numbers, but that is okay. So I think that is something that we're at the place with many providers where they're either going to stay or switch, because you don't want to stay with a system you don't want for 5 years. So I think we'll see a lot of, continue to see a lot of switching going on. Part of this may also be the fact is, as you mentioned earlier, quite a few EHRs do not have 2014 certification. So the providers are trying to figure out, well, are they going to meet 2014 certification? I was working with a client last week and trying to get them to test for meaningful use this year. And I contacted their vendor and said, what's your certification timeline? They said, well, we've already gotten some things certified. And I looked them up on the CMS health products list. They call it the chapel. And they gotten certified for privacy and security, which happens almost automatically. You're grandfathered for most of that from 2011. So we're kind of having to wait and hope that they get 2014 certified. And that's part of the uncertainty for providers. Are they going to get everything certified in time for me to achieve meaningful use this year?
So in that case, would there be kind of some thinking on the provider's part about if they're not able to attest for that stage 1 using 2011 certification, might they need to apply for a hardship exemption, or what's your thinking on that?
Yep. Absolutely. There is no penalty for applying for hardship exemption for EHR-related issues. So if you're not on 2014 software right now, I would Google CMS meaningful use penalties exemption form, and I'd fill it out today, and I would email it in. Because if you're not on 2011 software now, again, we're within just between 2 and 3 weeks from the deadline to apply for that hardship exemption. And CMS has said it's okay if you apply for that exemption, but then you end up not needing it. Don't have to claim it. That's okay. So, yeah, if you're not
cover
using
your bases.
Yep, and that's fine, and that's understood by CMS. Sure is.
Well, would you like to make some other remarks, Jim, before we get to questions?
No, let's go. Let's see what we've got, Brian.
All right. Well, we've got a lot of questions from our audience, so we certainly don't have any shortage of those. All right. I'm just going to read these to you and let you answer as you think best.
Okay.
So it says, is it okay for your EHR to add CQMs during the reporting period, or do they all have to be certified by the start of the reporting period?
That's a fantastic question. For 2011 software, and 2011 is stage 1 rules, 2011, 2012, and 2013, there was a requirement for the EHR vendors for eligible professionals to do at least 9 quality measures. I believe hospitals had to do 15. There was no choice about them. But for the eligible professionals, there was a total of 64 possible ones. Vendors for the eligible professionals had to do at least 9. And so if they tested 9, but then later, or maybe they had 64 there, but they only tested and certified 9, CMS allowed to report, the provider to report on CQMs that had not been tested. However, the stage 2 rule, which goes into effect for 2014, very clearly says that the only ones that can be reported on were CQMs that were actually tested and certified. So that is a change for this year. So you can only report on ones this year that were tested and certified by your vendor.
All
so
right.
if they add ones later, they can go back and show new CQMs to their testing body and get those certified. But each CQM has to be tested and certified.
All right. Well, that's good advice.
It's in the final rule for stage 2. I Googled it about a week ago and found that text.
So this relates to this next question relates to the hardship exemption, and I think you've touched on this, but let's just talk about it a little bit more. The question is, how does one qualify for the technology exclusion for stage 2? If one does, do we have to reattest for stage 1 for the year?
Let's see, I'm trying to think exactly what is being asked in that question. For the technology, and so I guess this is for the EHR related issues. That's probably it. There is an exception allowed for EHR related issues, meaning your EHR didn't get certified in 2014 or certified so late they didn't have time to implement it to you. And so if that's the case, you do the hardship exemptions. You don't get penalized starting January, but you're sound like the question is, what happens if you skip a year of meaningful use? Well, if you skip a year of meaningful use, of course you don't get the incentive that year, but you don't go back to where you were. It's like if you had to do 2 years of stage 1 and then go to stage 2. So you do the first year, the second year you skip. Well, the third year is not going to be stage 1. It's going to be at stage 2. So you have to keep moving forward on meaningful use, even if you skip a year.
Interesting.
I think that's the question.
Yeah, I don't think most people realize that.
Yeah, they're very clear about that.
Here we have a question about the final rule. When you talked about the proposed rule, the question is there an expected date when that rule will be final? I've heard September, but that makes it difficult for planning, which you obviously have talked about quite a bit.
Isn't that the truth? I think the end of the public comment period is July 23rd, and I encourage everybody to go make public comment. I looked about a week and a half ago, and there were 8 there, and then I looked more recently, there was 132, so maybe there's a lot more now. I don't know. It's kind of fascinating to go read them. You can go read them. So at the end of July, that'll be closed. I didn't hear it, but there was a CMS call a week or so ago. A colleague of mine was on, and they said they expect it sometime in September. CMS was saying sometime in September. Very, very difficult to plan on, and so that's kind of what we've been talking about, Brian, the lack of a clear foundation to make plans on. So to me, the best advice is pretend like there is no proposed rule. Go ahead with trying to do everything you can for 2014, as well as that hardship exemption. If you're in line for stage 2, try and achieve stage 2. And if they give us in September a birthday present with this final rule giving us some leeway, then you can take advantage of it. Very difficult to plan. You really can't plan without risk. Yeah.
Another question we have is there any word on reduced reporting periods for 2015? Might they go with a quarter then, or is the plan still for a year? That's great.
No, it's still for a year, and the proposed rule reinforces the fact that January 1st, 2015 or October 1st, 2014 for hospitals, it's going to require the 2014 software and no change to the reporting period. Now, of course, for Medicaid, always the first year Medicaid, no matter what your first year is that acquired, implemented, upgraded. Don't have to achieve meaningful use. Second year Medicaid is always 90 days, so the third year is a year. So that will stay in place. And for Medicare, there's always 2 years of stage 1, no matter when you start. That first year can be 90 days, but for the rest of us who do 90 days this year, we're in line for a full year in 2015. So you kind of see the thing here is that this proposed rule even goes through. The biggest thing would just be a delay in 3 months, saying we don't have to have 2014 software right now. It's until October, November, December. If proposed rule becomes final, well, it shifts it 3 months to January 1st. So it's, but I've heard nothing that implies that they would not require a full year in 2015.
So here's a question I think you've addressed, but it's worth touching on again. is there any backlash with applying for hardship exemption and then discovering that you'll actually be able to attest in 2014?
No, we did address that, and CMS has said that's fine. It's okay if you think you might need it, you apply for it. If it turns out you don't need it, that's well and good, because maybe you got the EHR installed or your system got certified in time, but you just can't take that chance. If you don't have 2014 software, that you're going to have it in time. Too many things can happen, and they have CMS has put out clarification guides to that effect, that it's okay to apply for it and not need it.
So here we have somebody who's just starting off. They say if you're a first-time Medicare MU provider and you need to complete 90 days by 10/1 and in effect start by the 1st of July, when the proposed rule doesn't end until July 21st, it comes back to some of the confusion you were talking about. Are these people who should start on a 2014 EHR, or what's your thinking here?
Yes. They're at a little bit of a disadvantage, because there are a couple strategies here. It sounds like it'd be very confusing to try and start on 2011 version and then upgrade within a month or two to 2014 and try and learn those workflows. That seems really difficult to me. And I don't know if there are many vendors out there who are going to want to install, implement, and configure 2011 back from the dead version of EHR. But if it's their first year and they can't get 2014 software, they can go ahead and apply for that hardship exemption. And then hopefully they can have that 2014 software in time for October, November, and December.
We've had a couple of...
Even though it's their...
Oh, go ahead, I'm sorry.
Well, I'll just say, even though it's their first year, we kind of hear they have to attest by October 1st for their first year. That just means to avoid the penalties. But if they file that hardship exemption for a legitimate reason, they can't get 2014 software, they won't have the penalty, and they can do October, November, December.
So we've had several questions about portals. Here's one of them. If the provider is attesting for stage 1 in 2014, does their portal need to be active during that reporting period?
Yes. Stage 1, 2014 software this year, the portal has to be active and data has to be pushed. Patient information has to be pushed to that portal. If they're at stage 2, patients, 5% or more of unique patients have to come to the portal. But stage 1, they have to make that information accessible through a portal.
So there's essentially no threshold if you're at stage 1, but it has to be active. Is that correct?
Well, there is a percentage threshold, and I'll have to, I may be incorrect about this, Brian, but I think within 3 days of a, correct me, somebody can correct so we're wrong, but within 3 days of a patient encounter, that information needs to be on the portal. And I want to say at least 50% of encounters.
And so when it comes to go ahead, I'm sorry.
I would say my numbers may be a little bit off there, but there is a percentage threshold and there's a timeline of when those providers have to have that information at the portal for the patient to access.
And so with the portal and secure messaging, if you're passing secure messages through the portal, does that meet the secure messaging threshold? Okay.
Yes, it does, and many vendors have secure messaging set up through their portals. And no doubt about that. We haven't talked about the patients too much, but that's one thing it's going to be somewhat difficult for patients as we move forward and have portals. You'll have a portal for this doctor, portal for that doctor, portal from your dentist, portal from the hospital.
Right.
Innumerable portals. But hopefully some technology will take care of that before too long.
All right, I'm just sort of going through the questions. We're nearly out of time. We might have time for just one more. And remember that we're going to send all these on to our presenter, so he'll follow up with you. But here's a good question about the security risk analysis. When it comes to being audited, how much are they going to look at basically what you've done with the risk analysis? How much do they look at the mitigation? Did you actually fix the problems?
Right. I asked the Medicare auditors this exact question about a week or so ago, and they confirmed that they look at every one of these documents. They want the whole document uploaded to them. And so they look at them. They want, part of what they're looking for is that when risks are identified, their severity level is identified. If something is low-level risk, they want that. You know, there's and all the documentation from CMS about security risk assessments talks about this ability to almost triage out the risk level. So that is part of what is important, but also, like say, a mitigation plan. Let's say there's something that's has been identified, and it's not a super high risk, but and so it's put on a timeline to be taken care of first quarter of next year, or November 2014, something like that. You know, there's no problem with things like that. You were talking about security risk areas. You know, one of the biggest ones hardly ever gets thought about is large copiers. Almost every copier has a hard drive built into it, and when those copiers go out the door, I've seen people take those hard drives, print out everything that's in them.
Mm-hmm. And there's a huge fine given to a company, I believe it was an insurance plan, for failing to properly dispose of the hard drive and its copiers, because there were thousands of health records in there.
That's right. And so there's a real benefit of doing this because doing a security risk assessment. And somebody, I would never have thought about that till a security risk expert brought that to my attention. So there are a lot of things that you know, a professional really knows about and knows you know, where the gaps really are. So
yeah, I think
they're looking to make sure.
That's good. That's good advice on why doing it yourself is probably a mistake, because you're just not going to see the same environment that a specialist is.
Exactly. You really don't know where a lot of the risks are. Yeah. I agree.
All right. Well, I'm afraid we're nearly out of time, but remember, we're going to take all the questions that we didn't get to, and we'll send them on to Jim, and hopefully he can follow up with you and give you some clarity on some of what you've asked about. I have to thank you so much for joining us, Jim. Very informative session.
Brian, always great talking to you. Always.
Well, we love having you here. To learn more about our industry expert, Jim Tate, and his services, please visit www.meaningfuluseusaudits.com. And you can learn more about Jim and how he can help you with meaningful use, and if, God forbid, you ever are in an audit situation. I'd also like to thank our attendees. Remember that all registered attendees will receive an email with links to both the recorded and PDF versions of this session. So look for that follow-up email if you'd like to share this event with anyone who might benefit from it. If you need a greater understanding of how to attest and keep up with meaningful use, join us for a 4-day accelerated workshop series led by Joy Rios, who's a popular contributor to our Learning Lunch series on meaningful use. This 4-day workshop series will provide comprehensive training for both eligible professionals and hospitals on both Stage 1 and Stage 2 of meaningful use, clinical quality measures, and more. You can register for the event by clicking on this link when you get the follow-up, or if you just visit www.formedtraining.com, or formedlearning.com. That's www.formedlearning.com. Scroll down to the workshop. If you use the discount code from our friends at High Tech Answers, you'll get a reduced price of just $3.99. It's a great value for this series. Visit formedapprove.com and click on the Learning Lunch button to see our upcoming events. Our next Learning Lunch has the title, A Simple Solution to Access Legacy EHR Data. So if you are switching over between EHRs, getting access to that legacy data is certainly a very important consideration. Keep an eye on your email box and our homepage for other upcoming topics. And thank you again for joining us today.
Thank you, Brian.